Good morning, everyone, and welcome to a, depending on where you live, either a partly cloudy, partly sunny, or really dreary day on Webinar Wednesday. Welcome aboard. For those of you who are joining our webinars as kind of part of that series, thanks for coming on again today. And for those of you that are new to webinars, you're in for a treat. Today we will be offering a session on fetal alcohol spectrum disorders, early childhood presentation and developmental trajectories, offered by Dr. Kathleen Kastner, or Katie, and by a wonderful parent, Debbie Freke. We will be, just so you can kind of see who these folks are, here are their lovely pictures. Katie and Debbie will tell you a little bit more about themselves when they get into their presentation. So just kind of follow along with pictures. You have a couple of facilitators today. Maria, that's me in the top, and Alyssa Jones, who is also helping us in the background, making sure that we get all of our polls and all of the other little details taken care of. So these are the folks you're going to be hearing from today. A couple of things just to do some housekeeping work here. You will get a certificate of attendance after today's session. You should get an email from the EI training program, and in that email after the webinar is completed will be a survey link, and once you complete that survey, you should be able to, you should get a certificate of completion within 24 hours of that. So be on the lookout for that email link. So webinars are wonderful, and we've got some folks who are logging in from some distance. Casey from Florida on vacation, checking this out. Awesome. But as you know, you're sitting in front of a computer, and that can get a little difficult. So we do want you to do what you can to participate, stay engaged in the conversation and the presentation. So we do have a couple of ways to encourage you to do that. The first is up at the top on the left-hand side where your name is. You will have 4 little boxes. You will use these boxes throughout the session today. The first one is a little emoticon box where you can just kind of indicate your emotion for that moment. I've put a little smiley face next to me. The second one we don't really use, but the third one is also a hand raise. Our presenters might ask you a general topic, general questions where they might just ask by show of hands, how many of you done this or done that? And you would just click on that 4th box and it'll raise your hand. So you can kind of see I'm doing that now. The 4th box is a polling function that I will explain here in just a second. And down below, you should have a chat box. And in the chat box, you should be able to see a lot of the conversation that's taking place right now. In this chat box, we ask that you type in any questions that you might have for the presenters. We will have built-in question breaks throughout the session today, but in order to be able to address questions at that break, we need you to ask your questions as you think of them so that we will collect those and have them ready for when the break comes up. Also, please feel free to use that chat box for whatever purpose you would like to have. If you're going to want to share strategies, just have conversation with somebody you haven't seen in a while but recognize their name. This is a great way to be able to participate and stay engaged in the presentation. The polling function is that 4th box that is under your name. It will sometimes have a letter like it does now, or it might have a check mark, which would be when we have yes/no questions. So I'd like for you to test it out, try it out, let us know who all is sitting in our webinar today. You have a choice of 5 answers, so click on that 4th box and indicate to us whether you are a parent caregiver, an EI provider, CFC staff, an administrator, or an other. And if you are an other, please, in the chat box, let us know what your discipline is or who you are or who's on here today. We'll give folks a few minutes to let us know what who they are. And as we're waiting on folks to respond, I'm going to plead a little. So I'm pleading that if you are sitting here, that you really engage and take time to answer these polls. It really does provide a lot of information for our presenters when they do have these questions. Gives them some feedback, just like if you were in a face-to-face and the presenter asked you to raise your hand or something like that. This is a way that they can see your responses, because otherwise they're just sitting at a computer as well. Let's see who we have here. So, Katie and Debbie, it looks like we've got a good number of CSC staff and early interventionists. We've got some administrators here, and looks like some of the EI providers are letting us know we've got some DTs on board here. And then there are a few that we're not certain yet, so we'll see who they are a little bit later. So, with that being said, I want to thank everyone for participating, and I encourage you to do that in future polling that we have. And so with that being said, Katie, Debbie, I'm going to turn it over to you, and I will let you,
Thank you
introduce
so much,
yourself.
Good morning, everybody. This is Katie Kastner. I'm really excited to be with you all this morning to talk about fetal alcohol spectrum disorders. Just a little bit more about myself. As Maria mentioned, I am a fellow in developmental behavioral pediatrics at University of Chicago. I've been in Chicago for about 10 years now. Moved here to start my medical training, and I'm nearing the end of my training in fellowship here, finishing up with the specialty of developmental and behavioral pediatrics. I've done a couple rotations where I've gained some exposure to fetal alcohol spectrum disorders, so I'm looking forward to talking with you guys about this today. And I'm going to take a second to have Debbie introduce herself and tell you a little bit more about who she is as well. Debbie?
Good morning. My name is Debbie Freke, and I am a parent of a couple of kids, an adoptive parent of a couple of kids that have fetal alcohol syndrome. I work for the Department of Children and Family Services, supporting foster and adoptive parents, of which a lot of them have children with fetal alcohol syndrome. I have been a foster parent myself for 27 years. I'm not anymore. We recently gave up our license, but we did foster for 27 years, and during that time had numerous children that were drug or alcohol exposed. So I'm excited to share information on this because I think it's so important.
All right, thank you so much, Debbie. So we're going to go ahead and get started. So just a little bit of background about prenatal alcohol exposure. It may seem surprising at this point in history to think this, but it hasn't always been clear to society or even the medical community that alcohol exposure during pregnancy was a problem. There were, kind of scattered historical references in both early medical literature, but also just in different literature pieces throughout history where people commented on postulations that maybe there was a concern when a mother drank alcohol during pregnancy and the impact that might have on a developing baby. But this wasn't a clear-cut, understood phenomenon by any stretch. And there were even times in the past where doctors or other medical providers recommended alcohol as a treatment for some conditions associated with pregnancy. So some of the stress or anxiety that pregnant mothers might experience, sometimes providers would suggest drinking alcohol as a means of treating that. So it wasn't until the 1960s when the kind of broader medical community first started to investigate this a little bit more intensively. There was a publication in a couple different locations around the same time that looked at the link between alcohol exposure and the impact on the child who was subsequently born. Though there were these early reports in the 1960s linking the two and showing that there was a detrimental effect when a mother drank alcohol during pregnancy, it wasn't until 1981 that the Surgeon General officially issued their advisory against drinking in pregnancy. So this really hasn't been a known thing for a very long time if we look at the bigger historical picture. And in terms of thinking about the impact then on society and when the information became really well known, this book that's listed here, The Broken Cord by Michael Doris, was a pretty pivotal book in this field in 1989. It was written by a father whose child had been alcohol exposed in pregnancy, and the experience that the family described was very powerfully written, and it was one of the first times that the general population became even more aware of the significant concerns about alcohol exposure in pregnancy. So that brings us to where we are today. And just a quick poll to get started at the beginning of the webinar here. So everybody find that polling feature that Maria was pointing out earlier. And the question is, what percentage of pregnant women in the United States currently report drinking alcohol in the previous month? So pregnant women in the United States drinking alcohol in the previous month. Your choices are 0.5%, 2%, 10%, or 35%.
And I can see somehow I missed putting the letters up there, so just kind of go A, B, C, or D. I would appreciate that. Thank you. We'll give folks some 10, 15 seconds to respond, and really, if we encourage all of you to respond so we can kind of really see what the field thinks the percentage is. So we'll give folks a little bit more time. Let me see. I guess I better answer myself while I'm sitting here thinking, and I'm not cheating. I don't know the answer. So let's see. There we go. All right. We'll give folks make sure you're using the polling function, which is that fourth box under your name. I'll draw a little pointer on the screen. You can kind of look for that. All right. Let's see what our results are. Okay. So, Katie, Debbie, it looks like the majority of folks chose 10%, with the next highest one being the 35%. So, what do you think?
All right, you guys are right on the money with the 10%. So the answer is 10%. And this may have come across your news feeds in the last couple weeks. The CDC put out a report recently discussing fetal alcohol spectrum disorders and updating some of the evidence around current exposure in the United States. And their latest evidence is showing 1 in 10 pregnant women report alcohol use in the previous month. So you guys were right on the money with that answer. I think it's important to recognize that that is not an insignificant number. 10% of pregnant women using alcohol is still a large number of women in this country who are drinking alcohol during pregnancy, and kind of points to the significance of this issue and this topic and why it's so important to help educate folks about the presentation of fetal alcohol spectrum disorders. So when we dive into this in a little bit more detail, we can see that there is variability in terms of alcohol use throughout pregnancy. So again, this study was from a little bit earlier than the CDC's most recent study, but they also got around 8.5% of all pregnant women reporting any alcohol use, so around the same numbers. When we look by trimester, certainly the highest rate is in the first trimester, and that's probably occurring in many cases before women even know they're pregnant. Oftentimes you don't find out you're pregnant until somewhere around 4 to 6 weeks at the earliest, and so in that first 4 to 6 weeks, many women may not even realize they're pregnant and may continue to drink alcohol as they had done when they weren't pregnant. The rate drops off quite notably in the second and third trimester, but doesn't fall to 0. And as you can see, the rate of binge drinking is also still notable in the first trimester. So 6% of women reporting binge alcohol use in that first trimester, even probably before they knew they were pregnant. And when we think about this in the medical literature, binge drinking is defined as 5 or more drinks within a couple of hours. Obviously, there's variability in terms of a person's ability to metabolize alcohol, how often they drink, the timing within which they drink, but that's the kind of standard definition that's used in the literature. When we look at the prevalence of fetal alcohol spectrum disorders, the rate in terms of number of cases in the United States is quite high, actually. It's that fourth bar down on the graph here, and you can see that the rates are higher than cerebral palsy, than Down syndrome, than sudden infant death syndrome by quite a large amount. It is, by current estimations, somewhere around 40,000 new cases in the United States in 2014. So that is not a small number at all. All right, so we're going to jump to our next question, the true-false one. So back to that polling feature. And the question is, drinking 1 glass of wine daily in the third trimester is considered safe.
Okay, so find that fourth box under your name, which is a polling function. It should have a checkbox in it now, so the check, when you open it up, you'll have a choice of yes or no. We can count it when you use the polling function, so if you would, make sure you open up that fourth little box with the checkbox and indicate yes or no there. which would be the equivalent of true or false. So we'll give folks a few seconds here to see what they think. Looks like we can probably post our responses here, so let's see. Pretty much everybody says that is a false answer, Katie.
All right. So you guys are correct. The answer is false. I think if we all took a second to think about, our social circles and the people in our lives, I think you might be surprised how many folks actually don't know that that's not true. There's kind of some common thought among society that it's okay, particularly in the third trimester, to have some wine during pregnancy. There are some OB doctors who still state that this is true as well. But the CDC has been very strong in their stance that there is no safe amount of alcohol that can be consumed in pregnancy. We don't have any data about what level might be safe, and we have lots of data about the detrimental effects of alcohol during pregnancy. And so no amount of alcohol is considered safe for consumption at any point during pregnancy, per the latest information that we have. And the reason we think about why this is so significant has to do with the way that alcohol is metabolized in the body of a pregnant woman. So the placenta, if you think back to your high school science classes, the placenta is where substances can diffuse between mom's blood and baby's blood. The baby receives all nutrients, all oxygen from mom, and then through the placenta, and then similarly all waste that needs to be metabolized goes back across the placenta from baby to mom. This diffusion is an important location for the baby to receive everything they need and to be able to clear and process anything that is waste or toxic. When the baby is in utero, mom's blood alcohol level when she drinks reaches whatever level she's going to reach based on how much she's drinking, the timing with which she's drinking it. When mom's blood alcohol reaches that level, that is then the same blood alcohol level that the baby's blood is going to be exposed to. The alcohol diffuses across the placenta and enters the baby's circulation freely. So whatever mom's blood alcohol level, the baby's going to be exposed to that level as well. In addition, the baby's liver is immature and not able to help metabolize alcohol in the same way that mom's liver is able to metabolize alcohol. So when mom has a blood alcohol level at a certain point, her liver is working quickly to break that down, process the alcohol, and turn it into non-toxic, excretable metabolites. Baby's body is not able to do that at the same efficacy as mom, and therefore there's even some higher kind of toxicity to the baby than would be to mom because of that impaired ability to metabolize. In addition, the baby's tissues are developing. They're changing, they are growing all the time, and those developing cells and tissues are especially susceptible to the detrimental effects of alcohol. We'll talk in a little bit more detail about what that looks like and which tissues in particular are affected, but it has to do with the immaturity of the baby's developing tissues and cells that make it so susceptible to the alcohol that it's exposed to. And timing does matter. So I know I said a little while ago that no amount of alcohol is safe at any point in pregnancy, and that's true. But there are certainly critical time periods of fetal development where certain tissues are going to be more susceptible than others at that time in development. And it has to do with what is developing in the baby at that time. So if you look at this chart, we kind of outline the different periods of fetal development and what's happening at certain time periods. So if you look early on, week 3, week 4, the heart, the brain are starting to form. As we move into 5, 6, 7, 8, the early part of the first trimester, we're starting to form the limbs, the eyes, the ears, the facial features. And then as we move later in pregnancy, the remaining focus is on growth primarily for the baby once you get into second and third trimester, and brain development. So the brain is really susceptible throughout the entire course of pregnancy, and the other kind of anatomical features are most susceptible early on in pregnancy, because once the facial features are formed, for example, those aren't going to be impacted later on in pregnancy by alcohol consumption. There's no clear-cut relationship between timing, the amount of alcohol, and the pattern of alcohol use across the board, and that's because of the variability in terms of each of our bodies' abilities to process alcohol. We all have different genes, we all have different metabolisms, we all have different exposures to alcohol that impact our ability to process and break alcohol down, and that therefore impacts the amount of alcohol that the baby is exposed to. So we can't define a clear-cut relationship between the two, but we do know that binge drinking is especially dangerous, and that drinking throughout pregnancy, obviously, the more that you're drinking, the higher the risk is for the baby. We don't have a lower limit, like I said, where it's considered safe, but we do know the more alcohol the baby is exposed to, the higher risk there is for detrimental effects. That being said, you can't say because one woman drank X amount of alcohol, she's going to have worse outcomes for her baby than a woman who drank less alcohol. Because again, of that variability between people, their metabolism, their genetics, and their tolerance to alcohol. Interestingly, when we think about timing, postnatally, so once the baby's born, alcohol consumption in mom can still be a concern if mom is breastfeeding. Alcohol can be transferred from mom to baby through breast milk, and that alcohol is still going to be, in that scenario, exposed to the baby and their baby's developing brain. The American Academy of Pediatrics recommends that a mother not breastfeed for 2 hours after consuming alcohol, and that if she is pumping or nursing, that she should pump that milk and dump it so that the baby is not drinking the milk which contains alcohol, because it is readily transmitted in breast milk. So what are the effects of prenatal alcohol exposure? As you guys saw on the beginning slide, the term we use to describe this is Fetal Alcohol Spectrum Disorders. And the reason for that is that there is a wide range in terms of the impact on the developing child from prenatal alcohol exposure, both in terms of what is impacted and also in terms of the severity of that impact. When we think about the variety of outcomes that we can see, there's impairments in terms of physical development. You can have impairments in terms of cognitive development, behavioral development, executive functioning, emotional, and adaptive. When we think about physical development, the type of things we can see include abnormal physical features, which we'll talk about in some more detail, but then also physical development in terms of your motor skills. So you can see motor delays, clumsiness, balance problems. When we talk about adaptive impairment, that includes your self-care skills, safety awareness, your ability to navigate socially. Emotional, obviously, we think about mental health concerns, emotional regulation. Cognitive abilities are impacted in a number of children, and so that's your problem solving, your thinking, your ability to learn new information. Behavioral, so behavioral regulation, impulse control, and then executive functioning, attention, planning, organization, all of those higher order skills that we use in everyday life can really be impacted by prenatal alcohol exposure. So we alluded to this a little bit earlier, but the CDC released this publication just earlier in February, where they explored a little bit more about the current prevalence and scope of this problem. And per their data, they're reporting that up to 1 in 20 children in the United States may have a fetal alcohol spectrum disorder. There's obviously challenges in quantifying this number, a number that requires, this type of diagnosis requires knowledge about a mother's behavior during pregnancy, and that can be really tricky to sort out, both when the child is remaining with birth mother after delivery, but also when the child has gone into the foster care system after delivery. It can be really challenging to sort out exactly what happened during pregnancy. So it makes this number hard to quantify, but that's their best estimate at this point in time. We talked about kind of the variety of problems that people with fetal alcohol spectrum disorders can experience, and we'll go into more detail about that. And their estimates for this right now are listing $5.5 billion in costs for the United States, treating the aftermath of prenatal alcohol exposure. So it's a significant problem in this country, despite the fact that we've known for the last at least 30 years, more so probably, that this is a dangerous problem for developing children. So I'm going to hand it over to Debbie for a second, and she's going to share a little bit about her experience.
Debbie, we can't hear you, so you're going to need to turn your mic back on.
Can you hear me now?
We can, yes.
Okay, I'm sorry. This is, hard to listen to when you think about this is just also preventative. And, in my family, my children are adopted. I have biological children as well, but my children that are alcohol affected are adopted children. And we knew with one of them that the mother had drank heavily, probably every day, during the pregnancy. We knew that going, when my son was born, which kind of we had a heads up to be aware of looking for these things, which was an advantage. My kids are older now. My children are 26 and 18, so things have changed. There's a lot more knowledge about fetal alcohol syndrome now, although I don't think enough. I don't think it's, pushed enough or stressed enough or understood enough. My son, whose mother drank every day, has cognitive disabilities of somewhat, lower IQ. My kids did have the physical, which I guess you said you were going to be talking about later, the physical features of fetal alcohol. They've struggled in school, struggled socially a little bit. They've had a lot of strengths as well. My son was, just to show how different they can be, he had tremendous large motor skills. I mean, amazingly wonderful large motor skills. He was an excellent athlete, the national champion tap dancer, which was, kind of an unusual thing, but he was interested in that and did very well in that. In fact, when we saw the doctor, when he was diagnosed with this, we were told that was one of the best things he could have done, was to be a tap dancer, to rebuild some of those, pathways in his brain through the repetition of it and everything. So that was, kind of surprising to hear. My son struggles in adulthood now. He's 26, and some of these things are going to be lifelong problems that these kids do have. So it's just, it's difficult as a parent. It's difficult to see your child go through this when you think, gosh, this could have been prevented.
Thank you so much, Debbie, for sharing that experience. So we're going to jump into a little bit of the biology behind this. We know that the brain is particularly susceptible to prenatal alcohol exposure, and in particular there's a couple of regions that are most susceptible. The corpus callosum, which is highlighted in red on the diagram there, that's the part of the brain that connects the two hemispheres, and that's particularly important for motor, sensory, cognitive processing, and storing and retrieving information. Additionally, the cerebellum is particularly susceptible to alcohol exposure in utero. And if you remember, the cerebellum is important for controlling balance, movement, fine motor skills, but it also helps with coordinating input from a variety of different areas of the brain and moving that forward into, actions or cognitive processing or other kind of outputs from the brain. When we think about what happens on a cellular level, there's a number of different areas of impairment when a child is exposed to alcohol in utero. One of the main things that occurs is impairment in neurogenesis, and that's a big term which describes the creation of new neurons. So as new neurons are being formed in the fetal brain, we call that neurogenesis. And neurogenesis, we know, is impacted by prenatal alcohol exposure. A number of these kind of basic science facts that we're aware of come from animal models of alcohol exposure. So we're able to see what happens when a rat or a rabbit or a different animal is exposed to alcohol in utero on the cellular level. The growth and differentiation of neurons is impacted. Alcohol blocks that process, and that's really important in the developing brain because the brain starts out as one type of cell, and then the cells need to mature and differentiate into all the different cells that make up the brain, which serve very different functions. So that process of growth, but also importantly differentiation, becoming a unique type of cell to perform a unique process, is impaired. Migration is when those cells that are now unique and have a particular process move to their appropriate area in the brain. As you know, the brain is organized into there's different locations in the brain that serve different functions, and that process of cells moving to their rightful location is impaired by alcohol. Synaptogenesis is how nerve cells connect together so that they can communicate with each other. That process is impaired by alcohol exposure. Apoptosis is an ongoing process that occurs in the brain, particularly in the developing brain, where some of the cells that have been created actually need to be destroyed because they're not necessary, they are not needed, and the brain is kind of pruning down what's needed and what's necessary. The problem with alcohol exposure, however, is that this process of cell death or destruction of unnecessary cells is too widespread, and you end up destroying cells that you actually needed. And finally, plasticity, which is the brain's ability to recover from injury, to rewire, to re-network, to reconnect after an injury or an insult, is impaired by alcohol. Alcohol causes decreased oxygen supply via vasoconstriction, so constriction of the blood vessels in the developing brain. So overall, the whole brain is affected by decreased blood supply and decreased oxygenation. And all of this is variable depending on the genetics of the person. So different genetic variants might be protective against the effects of alcohol, where other ones might be even more highly susceptible. And there's some emerging evidence, though not well delineated at this point, that epigenetics play a role. And what epigenetics means is, you know, your parents' genetics may have been modified by their environmental exposure through their lifetime, and that can actually then be passed on to the child. And so there's some emerging evidence to show maybe mom or dad's environmental exposures, alcohol use, etc., modifies their genes in a way that then is passed on to the child. So all of this is impacting that developing brain in a really powerful way when the baby is exposed to alcohol in utero. All right, so we're going to take a moment and pause for some questions.
Katie, as I've been kind of watching, I've not seen any questions come in yet, but I do have one for you myself, and that has to do with does the fetal alcohol spectrum disorders, when a child is exposed to fetal alcohol, does that affect the size of the corpus callosum?
Yeah, so we do know that in general the brain size is affected by alcohol exposure. It is not the case for everyone, so it's certainly not something where you could, you know, do an MRI on every child and know whether they were alcohol exposed or not. But in severe cases of alcohol exposure, there are you know, post-mortem studies looking at the brain that have shown a decrease, a small size of the brain, and certain structures being more impacted than others. So it's not across the board, and it's not on a kind of linear trajectory that we would be able to reverse diagnosis and look at an MRI and say, oh, that child was exposed to alcohol. But we do know that that can happen in some cases.
Okay. Okay, well, there's no other questions at this point in time, but if you are in the process of typing one, we'll catch it at the next break. So I will let you go on ahead, Katie.
All right, thanks, Maria. So now we're going to jump into the diagnosis of fetal alcohol spectrum disorders. We've been using this term, FASD, for the entire talk now, but that actually is a term that encompasses a variety of different diagnoses. So we're going to dive into this in a little bit more detail. First, we're going to start off with a question relating to diagnosis. So the true-false question again, fetal alcohol syndrome is diagnosed at the time of birth. Is that true or false?
Okay, so make sure you find your polling function. It's that fourth box under your name. It has a little checkbox in it. If you click on it, you can open it up, and you'll have your choices of yes or no responses. So we'll give folks a little bit of time to respond to those, and I do encourage each and every one of you to do what you can to respond to these polls so we can kind of get an idea. I've not ever logged in on a phone or a tablet, so I don't know how these all look from those types of platforms, so I'm hoping that it's very similar. We'll give folks a little bit more time here, a few more seconds. All right, so the majority of folks say that it is false, that you do not, cannot necessarily diagnose at time of birth. There are a few that say they think you can. So what do you think, Katie?
All right, so you guys are all correct. It's variable. So sometimes this can be diagnosed at birth, but I will say that's rare. Most typically it is diagnosed later on. The situations where it can be diagnosed at birth, generally that's because there's a known alcohol exposure during pregnancy and the baby has notable physical features, which we'll talk about. The vast majority of cases this is occurring later in childhood or even into adulthood when the diagnosis is made. So fetal alcohol spectrum disorders is actually an umbrella term. So in and of itself, it's not a diagnosis. We can't bill under a fetal alcohol spectrum disorder because that is not a diagnosis. It's not a specific diagnosis. It's an umbrella term that describes several other diagnoses. And we are going to jump into these in more detail as we move forward here with the presentation. But just as the overview, the four main ones that we're going to cover are fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related birth defects, and alcohol-related neurodevelopmental disorder. We're also going to spend a little bit of time in this section talking about some of the uncertainty among diagnostic criteria and some of the changing kind of considerations about diagnosis that are occurring amongst the field, because there's some lack of consensus in a number of areas when we dive into this in some more detail. All right, so this is another graphic kind of showing that. So the first picture here is a graphical representation of all of these different diagnoses that we're going to talk about in more detail. So we'll dive into each one of these areas on the graph to talk about the diagnostic criteria for each of these disorders. The first one we're talking about is fetal alcohol syndrome. So that was the very first one on the slide back there. And with fetal alcohol syndrome, the child has to meet three main criteria. So one is they have to have facial abnormalities, which we'll talk about. You have to have gross impairment, either in weight or height. And you have to have CNS abnormalities. So each of these obviously have a lot of detail underneath them, and we'll talk about that in more detail. But the presence in each of these categories of these clear symptoms has to be present for the diagnosis of fetal alcohol syndrome. Interestingly, you do not need documented prenatal alcohol exposure to make a diagnosis of fetal alcohol syndrome. And that's because these facial abnormalities are very specific, and with a couple exceptions that we'll talk about, really can't occur in other situations. So that constellation of findings that we see physically really is limited to alcohol exposure in utero, and therefore you don't need documentation from the mother or from someone else that there was alcohol exposure during pregnancy. And that's not the case with the other diagnoses we're going to talk about, so keep that in mind. So the facial features are one of the main criteria of fetal alcohol syndrome, like we talked about. Now this picture comes from the American Academy of Pediatrics. I will say clinically this is a very extreme representation of the facial features of fetal alcohol syndrome. So most children with fetal alcohol syndrome don't look dysmorphic. They don't look that clearly abnormal to other people around them, whereas this child kind of does. So just keep that in mind. But it does highlight the differences that we can see in fetal alcohol syndrome. And the ones listed in blue on the left-hand side are the required physical features to meet the criteria for diagnosis. You need small palpebral fissures. So palpebral fissures are it's the opening in your eye between that inner corner and that outer corner. A smooth philtrum, so that's the portion of your upper lip between your nose and your lip, and then a thin upper lip. So you have to have all three of those. You can have some other physical findings as well. Those are listed over on the right, but those are not necessary for the diagnosis. So this is actually the cards that are used to help rank the smoothness of your philtrum and the thinness of your upper lip, because it's obviously kind of a subjective thing to determine. There are differences based on race. Obviously different races have different consistency in terms of how thick the philtrum is, or excuse me, an upper lip is, or how smooth the philtrum is. So you want to use the correct card for the race of the patient. And unfortunately, this time there are not standards for any other races besides, as you can see, Caucasian and African American, and that's definitely an area of need that a number of researchers are working on. But as you can see, it's going from the top, the ranking of 5, that upper lip that is very thin. You can not see much of the upper lip at all. And then the philtrum, the space between the nose and the lip, is smooth. There's not really even a hint of a depression there at all. As you move down the rating chart, you can see that the depression becomes more clear for the philtrum, and the lip becomes thicker. These pictures are what is used by physicians or whoever when they're making a diagnosis of fetal alcohol syndrome, and you need a ranking of a 4 or a 5 to meet criteria for fetal alcohol syndrome, and you need it both for the lip and the philtrum. So if you just have one and not the other, then that doesn't meet the diagnostic criteria. You have to have both. Palpebral fissures was the other physical finding that I mentioned that you need to have to meet the diagnostic criteria for fetal alcohol syndrome. This is actually really tricky to measure. So there's two kind of accurate ways to measure it. One is on the upper right-hand side picture, where they're using what are called calipers. So you place this instrument up against the eye, you line it up with the inner and outer corner, and then the machine measures the distance between the two prongs. That obviously is not something that we as pediatricians use ever, because it's very difficult to get a small child to sit still enough to make sure that you're not going to injure them by using these sharp metal objects. In the lower left-hand picture, there is, as you can see, a red line measuring the distance of the inner to the outer fold of the eyelid, and this is done through a computer-aided measurement system. So you take a photograph of the child, you have that white square in between their eyes, which serves as the legend, basically, helps the computer to have a standard size, and then the computer calculates the size of the palpebral fissures. And the measurement of the palpebral fissures needs to be at or below the 10th percentile to meet criteria. So again, you have to have all three of those to meet criteria for fetal alcohol syndrome. So you can't just have one or two, you have to have all three. These are just some charts that we use when we're looking at palpebral fissure length, again with the percentiles documented out based on age and gender. This is another way that we can calculate it, again using the measurement. You can enter the information and get a Z-score out, which is another way of looking at the percentile that the child's palpebral fissure is measuring. So these are several children who have fetal alcohol syndrome. They each have been diagnosed with meeting all three of the criteria for the facial features. And as you can see, they don't look abnormal, right? They're not children who would necessarily look clearly abnormal if you met them in your practice or on the street. And so that's why it's really important that if you have concerns about a fetal alcohol spectrum disorder or fetal alcohol syndrome, that they're evaluated in a clinic that has experience with this diagnosis, because it is something that requires a lot of expertise to make the diagnosis. Excuse me. The other category that we talked about was CNS abnormalities. There can be several different ways to meet this criteria. One can be through having a small head circumference below the 10th percentile. Also, you could have clinically significant abnormalities observable on brain imaging. That, I would say, is not the most common way that people meet the criteria, but that is another possibility. Neurologic problems, other than what you would expect based on their medical history. So if they have clear-cut neurologic abnormalities that are not explained by something else, then that can meet the criteria. But far and away, the most common way that people meet criteria is through this last category, which is functional impairment. And we'll talk about that in more detail here. So under functional impairment, you can either meet it through global impairment or, again, functional impairments in several different areas. So with global impairment, you would have to have cognitive or intellectual deficits in multiple domains of development that puts you more than 2 standard deviations below the mean based on standardized testing. So that's a pretty significant delay in at least 2 different areas that will give you meeting the criteria for this diagnosis. Alternatively, with the functional category, you can have milder deficits in 3 different domains that can then fulfill the criteria. So 1 standard deviation below the mean on standardized testing and at least 3 domains can fulfill that criteria. There can be a number of different ways that this is measured, so looking at cognitive skills, executive functioning, motor functioning, language, attention hyperactivity, social skills, sensory problems, pragmatic language. All those different domains can count as some of the domains that are impacted in this diagnosis. So that's fetal alcohol syndrome. Again, you'll see it's the one on the top of this chart here. You have to have facial abnormalities. You have to have the growth impairment. We talked about height or weight less than the 10th percentile at any point, not explained by another reason. And then the CNS abnormalities, again, not explained by another reason. If you have all 3 of those, that meets the criteria for fetal alcohol syndrome. If you don't have all of those, but you have some of those, and you have a known confirmed exposure to alcohol in utero, then that would fit with that next diagnosis down, partial fetal alcoholic syndrome. Again, you have to, in this case, have the exposure to alcohol being documented because you don't have all the features of fetal alcohol syndrome. But if you have the known exposure and you have some of the features, then you can fit with this diagnosis. So maybe you have some but not all of the facial features. Maybe you have the growth impairment and the CNS abnormality but none of the facial features. So again, this is one of those where you have some of the features but not all of them. The next one down is alcohol-related birth defects. And this is a less common diagnosis, but in this situation there's a known confirmed exposure to alcohol with a structural birth defect. So there's variability here in terms of what that looks like. That can be a cardiac abnormality, skeletal abnormality, renal abnormality, eye, auditory abnormality, but again, a structural birth defect that's been associated in the past with alcohol exposure in utero, and the child has to have had documented exposure to alcohol in utero to fit with this diagnosis. And then the last diagnosis under fetal alcohol spectrum disorders is alcohol-related neurodevelopmental disabilities. And this one is by far and away the most common. In this situation, the child has a known documented exposure to alcohol in utero and then has CNS abnormalities and cognitive abnormalities. This diagnostic criteria is the least well defined of all of the criteria. There's still quite a bit of variability in terms of the definition depending on who you read or what source you're looking at. But in general, they all require prenatal alcohol exposure documentation, and they involve some degree of CNS dysfunction. So this chart, certainly you don't need to know the details of it. I put it up here to show how much variability there is in these diagnostic criteria between different sources. So each of these columns is a different kind of expert that has published about alcohol-related neurodevelopmental disabilities, and they have their set of criteria based on their research, and they're not all the same. So there's definitely some lack of clarity here when we're thinking about this diagnosis. But in general, the main tenets hold true, that you don't need the physical abnormalities, but you do need alcohol exposure in utero and then neurocognitive impairment, as we discussed with the fetal alcohol syndrome criteria. So impairments in global functioning or some milder impairments in a number of different areas. Interestingly, in the most recent edition of the DSM-5, which came out in 2013, in the back of that book, there's a section that's not used for clinical diagnosis, but kind of diagnosis that need more investigation or areas of research interest, where they talk about things that people are looking at and interested in but haven't reached consensus enough to make it an official diagnosis. And in that section, they listed something called NeuroBehavioral Disorder associated with prenatal alcohol exposure. So this is maybe the next step when we're thinking about AR&D, when we're trying to come up with some consensus for the diagnosis that's a little bit more clear-cut. And they listed a number of criteria that are similar but not exactly the same as the alcohol-related neurodevelopmental disabilities. Again, you have to have the confirmation of alcohol exposure, but they actually go into specifics about how much. So in the DSM, they're saying it has to be more than minimal, which they define as more than 13 drinks in 1 month, and more than 2 drinks on any occasion. And there's obviously some controversy around this because of the kind of general consensus that no amount of alcohol is safe. There's been some controversy about the fact that they require that the exposure be more than minimal in their definition. But as I said, this isn't a true diagnosis yet. This is still in the research stages. They list the requirement in terms of impairment and neurocognitive functioning with a little less detail in terms of, needing to do 1 standard deviation or 2 standard deviations. But you have to have impairment in neurocognitive functioning, you have to have impairment in self-regulation, and you have to have impairment in adaptive functioning to meet their criteria. So just something to know is on the horizon, and that these definitions are kind of changing and evolving as more research becomes available. When we think about what else could be going on in a child who's coming in for fetal alcohol spectrum disorder evaluation, there's a number of things to consider. First is genetic syndrome. So for the children who actually have the physical features that we talked about earlier, it's important to think about whether this could be explained by a genetic syndrome. So some of them are listed here that can have some of the similarities and overlap, but in general, none of them will look exactly like a child with fetal alcohol syndrome. They won't meet all of the criteria. There are some teratogens, chemicals or substances that if a mother is exposed to in pregnancy could lead to some similar physical features. Toluene, which is a solvent, and then valproate, which is a medication used to treat seizures, can have some similarities. And then what's much more common is thinking about the other comorbidities that could be going on in a child who comes in for this type of evaluation to explain some of the neurocognitive impairment that they're having. So ADHD is highly comorbid with fetal alcohol spectrum disorder, but there can also be some overlap in symptomatology. We'll talk about that in a little bit more detail. Trauma is highly comorbid. A lot of children who have fetal alcohol spectrum disorders are victims of trauma for a variety of reasons as well. And then autism spectrum disorder can have some overlap as well. So it's not to say that you can't have both, and it's not to say it can't be one or the other. It's just that these are important things to consider when you're thinking about the diagnosis. All right, so I'm going to hand it back over to Debbie, so she's going to share a little bit about her journey towards diagnosis with her children.
Make sure you turn your microphone on, Debbie. Debbie?
Can you hear me?
Yes. Yes.
Can you hear me?
We can
Oh,
hear
I'm sorry. Okay. My children did present with the facial features, with the central nervous system issues as well. The facial features can run a huge gamut there. When we look at those pictures of those little children that you showed, they did look like normal little kids. I mean, their features don't stand out. My son is the second child of a mother that went on to have 3 more alcohol-affected children after him. His younger siblings have their facial features almost make them look like they have Down syndrome. Theirs are much more significant, but getting that diagnosis is important. And I think it's important to go to someone who knows about fetal alcohol syndrome. I see many parents that I work with at DCFS that, they get a diagnosis of ADHD, or they get a diagnosis of nothing, in fact, where they don't get a diagnosis at all. Whereas if you go to a doctor who is, or a clinic or something who is well versed on that or specializes in fetal alcohol syndrome, they're able to determine and pick up on that right away. With my son, the doctor passed us in the waiting room on the way, before he'd ever met with us, passed us and said hello in the waiting room, and then was able to tell me right away, your son has fetal alcohol syndrome, just by observing his facial features. My kids have struggled in school. They've had learning disabilities, reading problems. They both have ADHD, not the hyperactive type, but the attentive. They both have terrible problems with attention and learning. The working memory has been affected a lot. They can study for a test and not remember a thing. They just don't have that memory. It's affected them in every way, every possible area of their life. They were both confirmed that their parents drank, so we did know that, with both of them going into it. So our eyes were open. We were maybe a little bit more, proactive and looking for services and things like that. But the services were hard to come by. School was difficult, and it's just been a journey.
All right, thank you, Debbie. I think she brings up a couple of really good points, which is the diagnostic journey can be quite a process for families, and there's certainly difficulty in accessing the appropriate providers, but also can be some uncertainty in terms of gathering that background information about what exactly the child was exposed to in utero. So, depending on the situation, if it's a foster or adoptive situation, it may be really difficult to track down that information. And unfortunately, where the science stands right now, if there are not physical features and you can't get the information about exposure and pregnancy, then you can't have the diagnosis of a fetal alcohol spectrum disorder, one of those. So it can be really challenging for families, and it's also difficult for them to consider this possibility that something preventable could have led to some of their challenges for their child. So helping to support families through the diagnostic process is a really important role that you as EI providers can play. We'll talk more about that a little bit later. Okay, quick break here if there's any questions.
We do have a few questions now. So first, Christine has asked, because both you and Debbie have mentioned that finding a doctor or a clinic that specializes or has a real clear understanding of fetal alcohol spectrum disorders. So what kind of doctor would make those diagnoses, and how would one find a doctor or clinic that has the expertise?
Yeah, so there's several different providers who can most commonly make the diagnosis. Certainly genetics doctors have some experience with making that diagnosis because they're helping with ruling out any genetic syndromes. Developmental behavioral pediatricians can make that diagnosis. Some child psychiatrists and child neurologists have experience with this. But I think what's most important is asking the provider that you're going to see, finding out if they have experience in fetal alcohol spectrum disorders, if that's something that you're thinking about or considering. And at the end, we'll talk some more about some specific local resources.
Okay. Another question that Kathleen has asked is that, can you speak on the long-term effects of fetal alcohol spectrum disorder in elementary school and high school, in addition to some of the things that Debbie has shared?
Yes, we're going to.
So hold off on that one. Gotcha. All right. There's also a question. Okay.
Yeah. We're going to dive into
if
that.
you have any guesstimates, Amy has asked, do you have any guesstimates on how many children don't get diagnosed, or how many are just assumed to be slow learners or have developmental delays? Do you have any guesstimates on that?
I don't have any specific numbers, but there is certainly thought to be a high number of children falling in that category. And that's part of what the CDC tried to encompass in that 1 in 20 number that they published, was they were trying to, based on the known evidence that we have, take those children into consideration. Because certainly 1 in 20 children aren't diagnosed necessarily with fetal alcohol spectrum disorders. So that's what they were trying to think about in that statistic. But I don't have any specific numbers for you.
Lastly here, Jeannie has asked if the expectant mother has signs of fetal alcohol spectrum disorder herself due to her own mother drinking during pregnancy, but the expectant mother herself doesn't drink. Does the child have, will the newborn have any chance of having some of the characteristics even though her own mother didn't drink?
That's a good question. So generally the answer is no. As I mentioned, there's some emerging evidence about this whole epigenetic phenomenon and the extent to which our genes are modified by our environment. But the general answer in most cases is no. If the child is not exposed to alcohol in utero, then the child is not going to have, they certainly would not have a fetal alcohol spectrum disorder. Whether they could have some mild impairments because of mommy's exposure is another story, but they're not going to have fetal alcohol spectrum disorder if mother herself
There is one more question,
and
the question is, does the actual diagnosis of fetal alcohol spectrum disorder allow that child access to additional services beyond early intervention? So I guess what the importance of getting that diagnosis, what does that enable that child to gain in addition, for that diagnosis?
Yeah, we're going to talk in a little bit about some specific kind of treatment modalities that you can use in children who have a diagnosis of fetal alcohol spectrum disorder, so that can be helpful. In addition, if the option is between the child having no diagnosis and having this diagnosis, certainly that's going to allow them to access services, especially after early intervention ends, because they will need a medical diagnosis to access therapies, or in the schooling system to be able to access educational supports. So that can be really important if there's no other diagnosis that the child qualifies for. And lastly, and I think probably more important in some ways, is for some families, having an understanding of where the difficulties are coming from and the ability to then reach out for support from a community of families who experience similar situations can be really important and can really help them face some of the challenges that they face as a family. So being able to identify and connect with a community of parents who are experiencing similar challenges.
Thank you so much,
really
Judy and Debbie. So we'll let you finish up your presentation.
All right. So now we're going to talk in a little bit more detail about some of the outcomes that we see from children who've been exposed to alcohol in utero. And as you remember, we talked through this image a little bit earlier, but just as a refresher, these are some of the main areas of impairment for children who've been exposed, but we're going to dive into that in some more detail. And so first we're going to talk about what this looks like in early childhood. That's when most of you folks are interacting with children who may be impacted by this, so we wanted to pull this age group out in particular and talk about what this looks like in early childhood. So in infancy, some of the neurocognitive effects that we can see are listed here, primarily thinking about regulation. So sleep can be highly affected. Children can have a really difficult time sleeping, or they may sleep too much. You can see difficulty in state regulation, so the ability to recover from the stress or the ability to soothe yourself as an infant can be impaired. Even autonomic regulation can be impaired. So, heart rate, blood pressure, those type of things actually can be poorly regulated in a child who has been alcohol exposed. You can see increased activity levels and increased stress response in babies who've had alcohol exposure. Habituation is affected. So habituation is the idea of, you get exposed to a stimulus, and over time that stimulus becomes less disruptive because you're used to it. And that process is actually impaired in babies who've been exposed to alcohol in utero. And obviously that can be really significant, right? Because the whole world to an infant is a new stimuli. And if these new stimuli remain really, really significant in terms of how you respond to them and they impact you, that affects the baby's ability to kind of adjust to life in the world. There's several studies that have shown, impaired stress response. So both on a physical level, looking at baby's facial expression and kind of affect state regulation, but also on an autonomic level, more significant changes in heart rate, cortisol level, things like that when faced with stress. We do know that babies who've been exposed to alcohol have a higher chance of being kind of irritable, and that definitely affects attachment, right? When a baby is irritable and fussy and hard to console, that can really impact a mom's ability to attach to that child. Kids, even in infancy, also can show developmental delays. So we can see delays as early as infancy in terms of motor, social engagement, things like that, when they've been exposed in utero. As we move into the toddlers, we start to see kind of more commonly, this is when symptoms begin to become apparent. People may or may not notice differences in infancy, but most commonly by toddler and preschool age range, we start to see difficulties. And the range of what we see is quite broad, but most commonly you're seeing difficulties in executive functioning, so impulse control, attention, behavioral concerns, behavioral regulation, difficulties in sensory processing, so we can see more challenges in terms of both sensory seeking and sensory avoidant behaviors. We see memory impairment in kids who've been exposed in utero, so they have difficulty learning and retaining new information, and then developmental delays, like we mentioned, can continue at this point. So speech can become an area of concern. In particular, visual motor integration is often affected. We have several studies that show worsening performance on standardized measures of visual motor integration, and then math skills as well can be another area that's particularly affected. And Debbie's going to just share real quickly about some of the things that her children experience in early childhood.
Can you hear me?
Yes, we can hear you fine.
Okay, I want to make sure. My children experienced a lot of these things as infants. They had developmental delays as toddlers into that 30% where they qualified for services with delays in development. They also had, a lot of kids have eating problems as infants. They couldn't, my daughter had to go to speech to learn to suck and breathe at the same time. She had trouble with swallowing, which was attributed to that. Heart murmurs, both of the kids had heart murmurs. Lazy eyes, that's very common in kids that have fetal alcohol syndrome. They both had to have surgery for lazy eyes. As far as the toddler, the memory is huge. Just learning that you could just see that the children would understand what was being said, but remembering it later, math skills were impacted, lifelong impact on the math skills, to the point of almost total not understanding the concepts of math, and which has made life difficult for them. So they've had a lot of these symptoms, and I agree with what Katie said before about these kids can have, they're born with this syndrome and they're difficult babies. My two weren't especially difficult babies, but working in child welfare, I see that a lot of these kids born to the moms and they have born to drinking mothers and have these behavior issues. Those are the kids that tend to be abused because these moms can't handle then the behaviors and the difficult babies that they have, and these kids tend to be abused and removed from their homes, which further traumatizes them. Those have been the kids that I pretty much deal with. So there are a lot of symptoms that you can see in early childhood, and then the early intervention services are so important when you can pinpoint what services that the kids need, because they need to get help, early on, that's for sure.
All right, thank you, Debbie. And as we move forward into childhood and adolescence, as Debbie mentioned, these effects are lifelong, and so they certainly continue into childhood and adolescence. A number of children are diagnosed at that point, and there's kind of some more specific impairments that we can see emerge in this age range. So cognitive outcomes is one of the main concerns that people talk about with alcohol exposure in utero, but the majority of individuals with fetal alcohol syndrome don't have intellectual disability, which is defined as significant impairment in cognitive functioning. But we do know that fetal alcohol syndrome is one of the leading causes of intellectual disability. So I know it's a little confusing, but if you think about it, not everybody with fetal alcohol syndrome has intellectual disability, is cognitively impaired, but that diagnosis is one of the most common causes of intellectual disability. Even if people don't meet the criteria for a diagnosis of intellectual disability, a severe cognitive impairment, we know that in general their cognitive scores tend to be lower than the general population, and we know that people who have fetal alcohol syndrome, as compared to the other spectrum diagnosis, have more significant impairment in their cognitive outcomes. There's some estimates that would say an average for fetal alcohol syndrome are in the 70s for people who meet that diagnosis, and for people who have other fetal alcohol spectrum diagnosis, the average IQ is somewhere in the 80s. 100, just as a reference, is the mean, the mean IQ, and an IQ less than 70 is considered to be the diagnosis for intellectual disability, among some other criteria. Executive functioning is highly impacted by alcohol exposure in utero. This is probably the most common area of impairment and one of the most significant ones. And as you can see on this graph, executive functioning involves a lot of different areas of brain functioning: organization, focus, sustaining attention, shifting attention, regulating alertness, effort, processing speed, managing frustration, modulating emotions, working memory, monitoring and self-regulation. All of these things are impaired in children who've been exposed prenatally to alcohol. This really impacts on functioning and quality of life for these children and for their families. As we dive into those in a little bit more detail, one of the main things that we see in children who have fetal alcohol exposure, as Debbie kind of alluded to, real difficulty with math, and in particular, understanding abstract reasoning. So understanding time, understanding money, those are very abstract concepts, and then understanding honesty, right? Why being honest, understanding figures of speech. These are all really abstract concepts that we use in our daily lives. But for kids who have fetal alcohol spectrum disorders, they can really be challenged to understand and can lead to significant functioning in significant difficulty functioning in everyday life. When you have an impairment in executive functioning, one of the things we think about most commonly is ADHD, and it is definitely the most commonly co-diagnosed disorder with fetal alcohol spectrum disorders. But kids who have both diagnoses as opposed to ADHD alone can look a little different. So the presentation of symptoms is generally earlier, and as Debbie alluded to in her situation with her children, is primarily the inattentive symptoms. You can have hyperactive symptoms, but more commonly when we look at a bigger picture, it's the inattentive symptoms that are sticking out. And they have worse adaptive functioning than kids who have ADHD alone. So adaptive functioning, again, is that kind of self-care, functioning in society, functioning in life. It tends to be worse in kids who have both diagnoses. There's some evidence about improved response to certain medications in kids who have both fetal alcohol spectrum disorder and ADHD versus in kids who have just ADHD alone. But I will say clinically that doesn't necessarily hold up, and it may be that we need to just try for each individual child a little bit more intensive approach. It may take a while to find the right fit in terms of medication management. Adaptive functioning, we've said several times, is impaired, so I won't belabor this point, except to add that social difficulties can be really common, and there's a wide range there in terms of what that looks like. So some kids just have more difficulty socially, all the way to the other end of the spectrum, where some kids with fetal alcohol spectrum disorder can also meet criteria for autism spectrum disorder. And this, we'll skip through this just because we're running a little short on time, but this is just a study that looked at the difference between kids who have autism alone versus also having fetal alcohol syndrome, and shows there's quite a bit of overlap between the symptomatology of the two disorders. So this is showing that, really over time, these challenges that start as a primary disability, impairment in memory, difficulty understanding abstract concepts, lead to lifelong challenges for people who are affected by this disorder. And if we look at it from a more objective standpoint, you can see a number of concerns throughout the lifespan. Increased really high rates in terms of mental health problems, difficulty functioning in school, getting in trouble with the law, confinement or incarceration is higher among this population, inappropriate sexual behavior, alcohol and drug problems, and then difficulties with independent living and employment. So this diagnosis leads to impairments across the lifespan, both in children and adults who've been exposed prenatally, and people need access to appropriate supports and services to really help them function to the fullest of their abilities in everyday life. I'm going to hand it over to Debbie to real quickly. I think she touched on this a little bit, but Debbie, is there anything you wanted to add about kind of your older childhood, adolescent experience briefly before we finish up here?
Turn your mic back on again, Debbie.
Hello?
We can hear you.
Can you hear me? Okay,
Yeah.
I'm sorry, this keeps going on and off. One thing I wanted to just stress real quickly, that it does go through the lifespan. Now, I am seeing that now at the stage that I'm in parenting these young adults now, and my daughter she drives, she does drive a car, she can't count money. She's 19 years old and couldn't look at a quarter and a nickel and tell you that that was 30 cents. She is in a transition program now with school, working on that. She's going to struggle with those things. My son has, unfortunately, a problem with honesty. He's 26 years old. He has a problem with that. He is an alcoholic himself. It is. We stress this through his life. You're going to have a predisposition to maybe have this problem, and he does. He does have that problem himself, and which is difficult. So this is, definitely something that goes through the lifespan, affects them forever.
All right, thank you, Debbie. And I think we're going to maybe hold off on questions till the very end here so we can get through the last section, which is treatment. So, and this poll too, we're going to skip over. So treatment is really important, and there are ways to help treat fetal alcohol spectrum disorders. It's, as with many things, a multimodal approach. So you need therapy, you need parent and family support, you need educational supports, behavioral supports, and then in some cases, medication to treat comorbid diagnoses. So there's not a medication to treat fetal alcohol spectrum disorder, but we can treat, if they have ADHD, we can treat the ADHD. If they have depression or anxiety, we can treat those medically. But for all children who fall under this diagnostic classification, these other modalities are really important. So making sure that they're getting access to therapy for any delays, behavioral support to help with that executive functioning, so teaching them skills about self-regulation, impulse control, organization, educational supports. Learning disabilities are common among this population in addition to the cognitive impairment, so making sure they're receiving the appropriate school supports as they move into adulthood. And then as children move out of their childhood into adulthood, they need vocational support, they need adaptive functioning support. Some, as Debbie alluded, some children, or adults, need support in terms of everyday functioning with money management, employment, self-care, things like that. It's really important for you guys as EI providers to help support families through this process. One of the most important things you can do is to help encourage families to seek evaluation if there are concerns that have been brought up, or if you have concerns, helping them understand why a diagnosis, and not even necessarily, saying a fetal alcohol spectrum diagnosis, but why diagnosis in general for developmental concerns can be valuable in helping them access services and helping them find a community of support. But then also really helping the family understand their child's strengths and weaknesses, and helping them see where their child is doing really well, and really help supporting them in understanding that, and then also help supporting them in understanding where things maybe are more difficult for their child, and helping them have a greater understanding of how to help support their child through those challenges. On this page, we don't have a ton of time left, but there are some really specific research supported modalities that have been developed to treat fetal alcohol spectrum disorders. They're listed here on the screen. Some of them are focused on adaptive skills, so tutoring and kind of coursework around adaptive skills. Some are focused on math, so really helping, like we talked about, math is a main area of difficulty, so helping support kids in their understanding and learning with math. behavioral regulation, and then family support. So really helping parents and families understand where their child's challenges are coming from, developing appropriate supports for behavioral challenges, and really helping to support the family as a cohesive unit moving forward. So each of these has a number of research to support it, and you can get some more information just by kind of Googling these different treatment programs. There we go. So I want to jump to resources real quick. So as I mentioned, there's a number of different organizations that can help support families who have been affected by fetal alcohol spectrum disorders. So people have talked a lot about NoFast. You'll see that on the lower right-hand corner. It's the National Organization on Fetal Alcohol Syndrome. They have a ton of great resources online, but they have a ton of great resources for families, support groups, different opportunities to connect with other families. The ARC, which is a larger organization that supports people with intellectual and developmental disabilities, has a particular subgroup focused on self-advocates with fetal alcohol spectrum disorder. And then the top picture there, the Fetal Alcohol Spectrum Disorders program, is for providers with, through the American Academy of Pediatrics, where you can get more information about this diagnosis. And in terms of local resources, I mentioned one of the organizations that I've spent some time working with and have learned a lot through is the Children's Research Triangle in Chicago. And they have a particular focus on fetal alcohol spectrum disorders and a lot of expertise. And so that's kind of clinically one of the places you can think about if you're local to refer families if you have concerns. All right, so I think I'm going to hand it back over to Maria. I know we're short on time. These are some of the take-home points, so you can see those up there on the screen, and they're in your handout as well. And thank you guys so much for joining us today.
I do want to thank Katie and Debbie for their information and insights, and it was a wonderful webinar. Thank you so much. Folks, the information that was on the screen is in the link, in the PowerPoint link that is posted on our notes page, as well as in the reminder email that you received. Ladies, thanks so much. We appreciate your time and information, and at this point in time, our webinar is concluded. Thank you so much.
Thank you.